Today we have the pleasure of hearing from Dr. Augusto Villanueva, a distinguished translational researcher in cancers of the liver. Dr. Villanueva completed his medical degree in residency in Spain, where he specialized in gastroenterology and hepatology. He first came to Mount Sinai as a research fellow from 2005 to 2008 while completing his PhD. His career then took him to Barcelona and London, and since 2014, he has been a member of the faculty here at Mount Sinai in the Division of Liver Diseases. His current research interests include genetic heterogeneity of tumors as a proxy for liver cancer evolution, development and validation of novel, minimally invasive biomarkers, and mechanisms of resistance to systemic therapies in liver cancer patients. Dr. Villanueva has published widely and has been the recipient of multiple awards. He also has an active role in education and serves as the co-director of the Translational Oncology track for the Masters of Clinical Research. Please join me in welcoming Dr. Villanueva.
Thank you very much. So start with my disclosures. I consult for two companies that are involved in developing products for liquid biopsy that I will briefly discuss today. This is the outline of my talk. I will first describe which is the current epidemiological data of liver cancer and the trends. What's the current status of the clinical management? So 3 years ago, I gave the grand rounds on HCC. There has been numerous changes in the management of HCC, mostly in patients at advanced stages. And finally, I will discuss two of what I think are major challenges and how we can address it using technologies that we're developing in the lab in the context of liquid biopsy. So this map shows the incidence of HCC worldwide. Red are the countries of highest incidence. As you can see, there is a geographic distribution in the incidence of HCC, high prevalence in sub-Saharan Africa and East Asia. The country with the highest incidence is Mongolia, 80 cases per 100,000 inhabitants. The distribution of the risk factors in Mongolia is quite even. So 25% is hepatitis C, 25% is hepatitis B, and 25% is alcohol. What is interesting in Mongolia is that the majority of patients with hepatitis B are co-infected with hepatitis delta. Here at Sinai, it's around 2%. In Mongolia, it's around 80%. And we don't know if that may contribute to the highest rates of HCC that we see in Mongolia. In China, China contributes 50% of the total number of liver cancers worldwide, and that's because hepatitis B infection, 8% of the population in China are surface antigen positive. And for example, Egypt is the country with the highest prevalence of hepatitis C. 15% of the population have hepatitis C virus infection. So there's a close correlation between exposure to risk factors and rates of HCC. There is a well-known and stable gender disparity in HCC by which males have highest incidence than women. The ratio is between 1 and 3. As you can see across different geographical areas, the bar is higher for men than for women. It's unclear which is the cause, but when you control for exposure to risk factors, the difference is maintained. So it's not that men drink more alcohol or are more exposed to hepatitis. There's something else that determines this increased risk in men. If we look at the data at Sinai, as you see, the catchment area is Spanish Harlem, East Harlem, and Harlem. The annual incidence is around 30 cases per 100,000, which is almost double than what we see in the Upper East Side or in other areas of New York and the whole United States. If we project the incidence of HCC in Harlem to the worldwide data, we see that we have an incidence that is similar to what is seen in East Asia, which is remarkable, one of the driving forces why the liver cancer program is self-developed here at Sinai. So what has happened in the last 20 years is there's been a steady increase in the incidence of liver cancer worldwide and in the US. Here you have data from the US between 1992 and 2013. Across different races, a steady increase in incidence. If we put that in perspective in terms of all the tumor types, despite HCC or liver cancer is not among the most prevalent tumors, you see that when we analyze the increase in incidence between 2009 and 2013 is the number one in men and the number one in women in terms of increased incidence in the United States. Similar happens with mortality. There is a steady increase in mortality between 1990 and 2014 of HCC across race and ethnicity. If we compare the data for different tumor types and we consider total number of new cases and total number of deaths, and we plot that for all the tumor types, The size of the tumor, the size of the dot being the relation between incident cases and mortality, which gives an idea of the lethality of the tumor. For example, you have here thyroid tumor that is relatively small because it's not a very lethal tumor as compared to lung cancer, for example. Liver is somehow in the middle, despite it's the second most lethal malignancy after pancreatic cancer. There are a number of singularities of HCC that we'll discuss across the talk, and this is the first one. We have a very fair understanding of the natural history of the disease. It's very rare to develop HCC if you don't have an underlying liver disease. So patients with normal liver, it's very unlikely that they develop a tumor, an HCC, I'm sorry. However, patients that are suffering from different forms of chronic liver disease, being viral hepatitis B, C, alcohol abuse, no-alcoholic fatty liver disease, and other causes like autoimmune hepatitis, PBC, etc., they are at increased risk of developing cirrhosis, which is the key risk factor for developing HCC. The annual risk of HCC in patients with cirrhosis is variable, but we can estimate that it's between 2 and 3% per year. And that's the rationale to recommend surveillance in patients with cirrhosis for the early detection of tumors, and we'll talk a little bit more about that. There's an alternative pathway of developing HCC in patients with chronic liver disease, but who has not developed yet cirrhosis. There are some patients with hepatitis B, some patients with NAFLD, and patients with advanced fibrosis and hepatitis C that can develop HCC without having cirrhosis, which complicates the approach to surveillance, and also which are the target population to include in surveillance programs, and we'll talk a little bit about that in a moment. So which is the contribution of the different risk factors to the global burden of liver cancer worldwide? As you can see here in different geographic areas, different colors that represent the different etiologies. Here in orange, you have hepatitis B. Here in gray, you have hepatitis C. And as you can see, the majority of HCCs are related to hepatitis B or hepatitis C. Now, there is a very effective vaccine against hepatitis B. Problem is that we still see patients that were not vaccinated, so that will take a while until we can solve the issue of hepatitis B. And you know there are very effective treatments against hepatitis C. So it's very likely that in the next 5-10 years, the HCC related to hepatitis or viral hepatitis will decrease. We have, however, an increase in another risk factor that is associated with HCC, that is non-alcoholic fatty liver disease. If you look at data from the United Kingdom, this is data from Newcastle, the number of cases between HCC cases between 2000 and 2010, and their group. The bars are colored based on the etiology, and orange are the HCCs due to non-alcoholic fatty liver disease. Steady increase throughout the years, and in 2010 represented almost 35% of all the cases. It's worth noting that in these patients, some of them do not have cirrhosis and were not diagnosed in the context of surveillance programs, so likely not at early disease stages. The other piece of information that suggests what is coming in terms of NAFLD is when you look at the liver transplant list in the US, the etiology that has increased the most in terms of cases listed is NAFLD. This does not mean that the majority of patients transplanted are due to NAFLD, but this is the one that has increased the most in the last 15 years. So to summarize, what we know currently in terms of the disease burden related to liver cancer is that incidence and mortality are both increasing worldwide. The WHO estimates 1 million deaths due to liver cancer in 2030. Is the tumor type that has increased the highest in terms of incidence in the United States. And we know the etiological landscape is changing. There's probably going to be less viral hepatitis-related HCC, and there will be an increase in NAFLD-related HCC. Now let's move to the clinical management and what we've learned in the last 3 years. So we go back to the natural history of the disease. As I mentioned before, patients with cirrhosis, there are an increased risk of developing liver cancer. The annual risk, again, is between 2 and 3% per year. That provides the rationale to include these patients in surveillance program for early detection. Now, the objective of surveillance in HCC is not to diagnose more tumors, is to increase survival. And that's key to understand some of the data that have been published recently that questions the benefit of surveillance in HCC. There is no level 1 evidence to support or to recommend surveillance in HCC. There is only one clinical trial, phase 3 randomized clinical trial published in 2004 that was conducted in China. They essentially randomized villages to undergo surveillance or not do surveillance. And they showed there was an increase in survival, but the trial was full of methodological, let's say, compromises, so it's not highly regarded among the community. There are a number of cohort studies, retrospective studies, meta-analyses, mathematical models. They all suggest that surveillance improves survival in HCC. This is one of the latest one from the group of Amit Singhal. So that's the rationale why professional societies from Europe, the US, and Asia, they all recommend surveillance in patients at high risk of HCC development. Which is the recommended strategy for surveillance? Well, what is accepted now is ultrasound every 6 months, plus minus alpha-fetoprotein. That has a pooled sensitivity for the detection of early stage HCC of 63%, which is not outstanding, I would say. But is the current standard, is what is accepted now. And which is the target population, so who should be surveyed? This is the summary of the 2018 American guidelines and the EASL guidelines, the European guidelines. They're very similar for the core patients that should undergo surveillance, because that's very straightforward population. There's some difference in some patients. I think the bottom line and the message is that any cirrhotic patients, no matter the cause, should be enrolled in a surveillance program if the patient is amenable for treatment. Because if the patient is not going to be treated, it's pointless to include in surveillance, because this will not change survival in this patient. You will not modify the natural history of the disease, and that's critical. In patients without cirrhosis, it's quite clear that patients with hepatitis C or any other etiology and advanced fibrosis should undergo surveillance. This is sometimes difficult to characterize, because sometimes you need a biopsy. You can use non-invasive tools to determine this, but it's less clear as in patients with cirrhosis. The main controversy is patients with hepatitis B non-cirrhosis, and the reason is the pathogenesis of liver cancer in hepatitis B is different as to the other etiologies, in the sense that the virus can integrate in the DNA of the host. So depending where it integrates, you can activate oncogenes, so you can have a tumor with relatively low degrees of fibrosis, and that's a little bit difficult to assess. And that's why you see here in the American guidelines that a lot of, let's say, groups of patients that can be recommended for surveillance in the context of hepatitis B. It's a little bit more controversial. So I just want to give you the message that any cirrhotic patient should be included in a surveillance program, and that's a big deal, as we'll see shortly. So when you have a patient and you identify a nodule in the context of surveillance, the next step depends on the size of the nodule. If the nodule is less than 1 centimeter, the likelihood of that being an HCC is very low. So the recommendation is to repeat the ultrasound in 3-4 months. If the nodule remains stable, repeat it 3-4 months, and if it's stable during a period of approximately 1.5 years, you can go back to conventional surveillance every 6 months. If the nodule grows in one of these controls or is higher than 1 centimeter, then the recommendation is to go for a diagnostic procedure. There's another thing, this is the second singularity of HCC, is that unlike most solid tumors, it can be confidently diagnosed without a biopsy. So if you do a CT scan and you see what are called the hallmark features of HCC, that includes hyperenhancement in the arterial phase and washout in the portal venous phase, you can call that an HCC with high confidence. This is an example, CT scan, cirrhotic liver. You see there's, the surface of the liver is very irregular. There's some ascites. You have here these nodules that light up in the arterial phase. We know arterial phase because the aorta is lighting up, and they wash out. So they're the first to lose contrast in the portal vein phase. So that's diagnostic of HCC. There's plenty of studies that correlate imaging with pathology, and it's very stable. The reason we can use this approach in HCC is because 2 reasons. The first one is that the pretest probability of a nodule in a cirrhotic patient, of a new nodule in a cirrhotic patient of being a liver cancer is very high. In a normal liver, it's not that high. So if you have a normal liver and you see a new nodule, it can be an adenoma, it can be a metastasis, it can be many things. It's very unlikely that it's an HCC. That's the other way around in patients with cirrhosis. The second reason is that the blood supply of HCC is different from the liver. So the surrounding hepatocytes, they're supplied mostly by the portal vein, whereas HCC is supported by the hepatic artery. That gives the specific pattern that we see in radiology. That's why we can diagnose HCC with imaging. But that only works in patients with cirrhosis. If the patient is non-cirrhotic, has a nodule, you need to do a biopsy to confirm the etiology of the nodule. This is very convenient because patients don't need to do biopsy, but on the downside is that we don't have access to tissue to do all the studies that we're very interested in conducting currently. And we try to figure out a way around that. So once you have the diagnosis of a patient with an HCC, you have a definitive diagnosis. The next thing is to stage the patient. To stage the patient, you need 3 variables. You need the liver function, performance status, and the tumor burden, the amount of tumor. And that's measured in 2 different ways: number and size of tumor nodules, and whether the tumors are within the liver or have spread out, either vascular invasion or strapatic spread, metastasis mostly in the lung and in the bone. Now, it's key to consider liver function, and there are different ways to quantify that. The traditional is the Child-Pugh score. It's been there for 60 years, heavily criticized because it contains objective parameters, but it's kind of useful. There are other ways to quantify liver function, like the MEL score and the Albig rate. It doesn't matter. You need to quantify, you need to make sure that the liver function of the patient is reasonable to apply the different treatments. And that's different from other solid tumors. You can have a breast cancer, you can have a colon cancer. The function of the breast or the colon is not determined, is not critical for the survival of the patient. Here it is. It's not the same to have a 2-centimeter HCC in a patient with a Child-Pugh A hepatitis C cirrhosis than the same 2-centimeter HCC in a patient with Child C ascites, cephalopathy, and a GI bleeding 3 days ago. It's the same tumor, but the outcome is radically different, determined by the background of the background liver disease. So this is the BCLC, the Barcelona Clinic Liver Cancer Algorithm. It's endorsed by the American and the European Societies for the Study of the Liver. It classifies HCC patients in 5 different stages and provides a specific therapeutic strategy for each of the stages. If we start with patients at early stages, there hasn't been major changes in the last 4 or 5 years. We know that surgical resection is the best therapy for patients with single nodules without clinically significant portal hypertension. And that's defined by measuring the HBPG, the hepatic venous portal gradient, which needs to be below 10 millimeters of mercury. There are other ways to quantify without the need to do invasive catheterism. The outcome of patients with single nodule treated with resection are excellent. So 5-year survival is about 70%, which is outstanding for a tumor, for a solid tumor, even with relatively large HCCs. The role of portal hypertension in determining survival has been shown repeatedly. There is a recent meta-analysis that I show here on the right that again shows that outcomes are significantly worse in patients with clinically significant portal hypertension. For those patients with clinically significant portal hypertension, an alternative is liver transplant. The story with liver transplant is very interesting because in the beginning, when liver transplant was applied to HCC, results were awful, were extremely bad. So patients died within 6 months with huge recurrences. So in the community, it was thought that HCC was not a good idea for liver transplant. Then when the number of transplants became more increased, they start noticing that in explants of patients transplanted due to non-oncological reasons, advanced cirrhosis, they found small HCCs. They were incidental tumors. But the outcome of these patients was not different from the ones without tumors. So Vincenzo Mazzaferro in Milan thought, well, maybe we're transplanting patients at, where they were too advanced. They had too much tumor. So he did a prospective study and showed that if you select patients with relatively small tumor, meaning 1 single nodule less than 5 centimeters or 3 less than 3, outcomes are comparable to patients without HCC. And that's key, and that's a milestone paper that was published almost 25 years ago. Now, you can refine this estimation. So depending on the number of nodules, depending on the size of the nodules, depending on the AFP, you can have an estimate of what's the 5-year survival of these patients when they are transplanted. Here's a nomogram developed by Mazzaferro, the same author. It was published last year. You can go online and you put the data of your patient. You can have an estimate of what will be the 5-year survival of the patient treated with transplant based on the number and size of the nodules and an AFP. The problem with transplant is that the resource is limited. So HCC patients need to compete with patients with advanced cirrhosis due to other causes that do very well with transplant. So that's the main limitation of applying liver transplantation in HCC patients, and that's why the criteria are a little bit restrictive, or some people think they're a little bit restrictive. If the patient is not suitable for resection or not suitable for transplant, it is an early stage, there's a third treatment option, radiofrequency ablation. This entails injection with a needle percutaneously. You get to the center of the tumor, and the needle, the tip of the needle gets extremely hot. It induces necrosis of the tumor, and that provides 5-year survivals comparable or similar to resection. You have here the data from the Italian group almost 10 years ago, 5-year survival around 55–60%. Now people start questioning, so if RFA ablation works so nicely, particularly for small tumors, can we use it instead of resection? Because resection is a little bit heavy on the patient. Can we do this approach that is much more simpler? And the answer is yes. There are a couple of trials, but they're not extremely terribly well designed. But the guidelines now recommend that in patients with small tumors that are located in a place of the liver that is accessible for ablation, ablation could be a first option instead of resection. We also have a very clear understanding of the patients that will develop recurrence. So recurrence is the main bottleneck of these curative therapies, mostly resection and ablation. So at 5 years, 70% of the patients with HCC treated with resection will develop a recurrence. And this comes in two different flavors. So you have a patient that has a tumor, you remove the tumor, but the tumor already has a small metastasis in the liver that you don't detect. You allow time for these metastases to grow, and you have a recurrence. That's early recurrence, is a true metastasis of the primary tumor. You have a second option, is that when you remove the tumor from the patient, the underlying liver disease is still there. So the patient is at risk of developing a de novo hepatocellular carcinoma. There's no another so the strongest predictor of developing an HCC is having an HCC in the past. So you have these two potential sources of recurrence. Using gene expression, we can tell which are the patients that will develop recurrence. If we add methylation data, we can even improve the prediction capacity to identify the patients with aggressive tumors that will recur early. These are included in guidelines, but they're not recommended. And the reason they're not recommended is that we don't change the management of the patient based on these data. They're not adjuvant therapies approved. There's nothing effective to prevent recurrence, so essentially we can do nothing about it. It's very informative, but unless you can do anything about it, the guidelines are a little bit reluctant to recommend them as standard of practice. The most controversial thing that happened the last 3 years in early HCC comes from this study that was published 3 years ago from the group in Barcelona. So essentially, they reported that in patients with early-stage HCC that had hepatitis C-related cirrhosis, and they were treated with potentially curative therapies like resection or ablation, they found an abnormal high rate of tumor recurrence when the patients were treated with the new direct acting antivirals against hepatitis C. So they found a 6-month recurrence of 30% when the expected is around 15%. So this generated a lot of editorial drama, there was a lot of controversy, and it's still not settled. People are saying that maybe we should run a trial and randomize patients to be treated with DAAs and not treated with DAAs. I personally think that will not happen. I question that that will be ethical. That's the latest data that we have published in Gastro this year by the group of Amit. It's a multi-center study that Sinai participated, Andrea Branch was part of the study, that showed that there are no differences in patients treated with DAAs or without DAAs in terms of recurrence after being treated with curative therapies for early HCC. So at this point, I don't think there is any robust evidence to recommend withholding DAA treatment for patients with hepatitis C-related HCC. If we move to intermediate stage, so these are patients that have more tumor, but the tumor is still confined within the liver. There is no extrahepatic spread. There is no macrovascular invasion. The liver function is acceptable, and the performance status is okay. The patients are recommended to receive chemoembolization. So this entails that to get a catheter to the hepatic artery, localize the tumor, and deliver doxorubicin. There are different formats. One is with drug-eluting beads, and then block the artery that supplies that particular tumor. So there is an embolic effect additional to the effect of the drug. So chemoembolization, you have here an example, CT scan, 3 tumors, arterial phase. You have the 3 tumors in the angiogram. The second alternative is very similar, but instead of delivering the beads, what is delivered are particles loaded with Y90, which is an isotope. that delivers local radiation. That's how the tumor is destroyed. So the data on TACE is very solid, it's very stable. TACE is, by the way, the most frequently applied treatment for HCC worldwide. There are a number of clinical trials. There's a meta-analysis that show that TACE improves survival for a median of 16 months to a median of 22 months on average. With radioembolization, with Y90, the data suggests or indicates that it's a safe therapy, which is important. And when you look at response rate, it's very similar to TACE. The problem is that there is no phase 3 randomized control trial comparing embolization against TACE, and that's why radioembolization is not recommended with level 1 evidence in guidelines, even though I think there is solid evidence to suggest that it's effective in patients at intermediate stages. Now let's move to the last stage, the BCLCC, advanced stage, with most of the things that happened in the last 3 years. These are patients who have impaired performance status, 1, 2, who have tumor outside the liver, either vascular invasion or extrahepatic SPED, metastasis in the bone or in the lung. The recommendation here is to treat the patient with systemic therapies, and there are different options that we'll go through in a moment. Sorafenib was the first drug to show efficacy in patients with HCC, the first systemic drug. This is the SHARP trial, was reported 10 years ago, was led by Sinai, and it showed that on average, it increased survival by 3 months compared to patients treated with placebo. It became standard of care in first line. Then we have 10 years of negative trials. Nothing happened. All the drugs fail in first line, in second line, superiority, non-inferior to sorafenib. They all fail until last year. Now we have lenvatinib that's shown to be non-inferior to sorafenib. This is the results of the trials. You can see the 95 confidence interval is 1.06. So the boundary established by FDA was 1.08. So the trial was positive for non-inferiority. And it was approved by the FDA. In second line, and all these trials were conducted in parallel, and the results were reported almost in a range of 2 years. So we don't have data to compare one against the other. Regorafenib, which interestingly enough is a drug very similar structurally to sorafenib, show efficacy in second line. So patients who tolerated sorafenib but progressed, so they developed progression of the tumor disease, they had increased survival with regorafenib. Cabozantinib is a MET inhibitor, the same. It showed improved survival in second line in patients who progressed to sorafenib. And the third one is ramucirumab. So ramucirumab, there was a first trial that was negative. So the authors conducted a sub-analysis, and they found that in patients with AFP higher than 400, there was a signal of efficacy with ramucirumab. So the company ran the second trial. In this case, they were only enrolling patients with high AFP, more than 400 nanograms per DL. And there was a survival benefit. So this is the first biomarker-driven therapy approved in HCC, ramucirumab in patients with high AFP. All these drugs are approved now in second line for HCC. What do we know about immune checkpoint inhibitors? So there were 2 phase 2 clinical trials. This is the first one. It was a large trial published in 2017. It showed that nivolumab was able to induce objective response rate of around 18%. What was remarkable and similar to other malignancies is that the patients who responded, the median survival was extremely long, or more than extremely long, it's remarkably long for what HCC usually provides. So the duration in half of the patients that responded, the duration of response was longer than 12 months, and this was across the different etiologies. Not that it was better in one etiology as opposed to the other. This was a rationale to grant FDA approval, accelerated FDA approval for nivolumab. There was a second trial reported shortly after, pembrolizumab, that showed a similar objective response rate, 17%. And again, the patients that responded, they do extremely well. They live, the lifespan is very long. We have a recent update. So the phase 3 trial of pembrolizumab against placebo in second line was negative. The phase 3 trial in first line of nivolumab against sorafenib for superiority was reported yesterday by the BMS, and it was negative. So the results overall of immune therapies in HCC are a little bit disappointed. I have to say, though, that we need to see what happened with these 17, 18% of the patients that do very well, because it may well be that these patients that do very well, they don't have, so the benefit of the effect is not enough to drag the survival curve and make it significant in an unselected patient population. We try to characterize the immune landscape of HCC, and this study was led by Daniel Garcia, and I collaborated with Joseph Lovett in this genomic study. So we analyzed 228 HCC patients, resected a specimen, so this is early HCC, and did gene expression microarrays and found that around 25% of the patients have significant activation of different genomic signals suggestive of immune active response. There are additional refinements of this class, and now we have kind of a spectrum of the immune interactions between HCC and immune cells. That ranges from the immune class that I mentioned before, around 30% of the patients is a heterogeneous class. There's a part called what we call the active, the immune active, and there's an exhausted. And at the other end of the spectrum, we have the immune excluded class. So around 30% of the patients completely cold. There are no immune cells in these tumors. There's not any single genomic signal suggestive of any active immune infiltration in these patients. Now, with this analysis, we're targeting early stage HCC, so these patients were not exposed to immune therapies. This is, samples collected more than 10 years ago. So we could not correlate these with response to immune-based therapies. So the next best thing that we could do is to take our signature that define the immune class and compare it with other signatures that in other tumor types have been correlated with response to immune-based therapies. And we find that in two signatures that associate response with melanoma. So we think that this could be the subclass of patients that respond, or at least a subset of patients of the 17% that responds, but we still don't have data to support that. So this is a summary of advanced stage HCC after the last clinical trials that were run in the last 3 years. First line, we have Sorafenib and Lenvatinib. There is no clear rationale to select one or the other, apart from the fact that Sorafenib has been there for 10 years, so there's much more clinical experience with Sorafenib. If you look at the secondary endpoints, response rate, according to mRECIST, are higher with Lenvatinib, but toxicity is quite similar between both drugs. In second line, we have, after phase 3 trials and approved by the FDA, all of these are approved, Regorafenib, Cabozantinib, and Ramucirumab. I have to say that all these drugs were tested after progression to Sorafenib. So even though they're second line, they were not tested after progression of Lenvatinib. And then we have Nivolumab and Pembrolizumab, who currently are FDA approved, despite the fact that the phase 3 trials were negative. So there's a background noise of whether the FDA will remove the approvals or not, and this is unclear, and probably we'll hear something the next days. There's another trial, 2 trials that I want to mention in the advanced setting, is that the application of Y90, and we talk about radioembolization for intermediate stage, and we discussed that could be a potential option. It was also tested in patients with advanced disease, mostly in patients with microvascular invasion. And the idea, and interventional radiology pushed a lot this concept, is that they could treat the microvascular invasion. So there were 3 trials, and these are the 2 that are reported. The third one has the same results, but it's not on paper yet. The 2 trials testing CIRT, this is radioembolization, against Sorafenib in first line for superiority, they were both negative. So you can see the curve seems to be a little bit better even from Sorafenib. So what we can say about this, after these trials, is that radioembolization does not improve survival compared to Sorafenib. What we cannot say, and it's been said every day, is that they're both equivalent. So these trials were not designed to test equivalence. So Y90 should not be applied, or hasn't shown to be, you can do anything, but it hasn't shown to be effective in patients with advanced HCC, and that's important to note. So this is a summary of the drugs that were tested in advanced HCC, in first line, in second line. You have the different drugs. Red are the negative trials. In blue, you have the positive trials. You have here the median survival for the active arm and the hazard ratio for the active arm. The lower, the better, so we increase the risk of death. A couple of lessons learned after all these years of trials, positive and negative. One thing that I found really striking is that when you look at the target profile of the drugs that are effective and the target profile of the drugs that are not effective, they're very similar. So for example, have here sorafenib, regorafenib, they're all these drugs that show efficacy in phase 3. Then you have all these drugs that are very similar in terms of the target that they block that were negative. There's some explanation in terms of how the trials were designed or the potency of the inhibition that suggests there could be toxicity in some of these drugs that inhibit more potently one target than the other. But still, it's quite striking that this similar target profile induces so different responses in terms of antitumor efficacy. There's a second lesson that I found really interesting is that, so here I have the results of sorafenib, published in 2008, effective in patients with advanced HCC. So people thought very reasonably, if it works in advance, I think we should test it at earlier stages. So the design trials combining effective treatments like TACE with sorafenib, there are 3 trials like this one, they're all negative. So when you add sorafenib to TACE at patients at intermediate stage, at early stages, it does not work. When you try to use sorafenib as an adjuvant therapy to prevent recurrence after resection, the largest trial reported so far in HCC, the STORM trial, is also ineffective. So the bottom line is the same drug that works in one stage does not work in other stages, and it's very consistent across different clinical trials, which suggests to me that disease stage matters, and that the disease evolves over time. When you have an advanced HCC, it's not just an early tumor with bigger nodules and more nodules, something's different. It's either the heterogeneity of the clonal composition, it's either the role of angiogenesis that may be different at different stages, we don't know, but it's clearly that the disease evolves over time in a fundamental way. So in summary, in terms of the clinical management, we can say that we need 3 parameters to stage patients with HCC: tumor burden, liver function, and performance status as encapsulated in the BCLC algorithm. That resection, transplantation, and ablation are potentially curative therapy options in HCC, and they provide acceptable survival rates. TACE is recommended in intermediate stages. The role of Y90 intermediate is debatable, but I think there's enough evidence to support its use. That there are 5 drugs effective at advanced stages, but the efficacy of checkpoint inhibitors is disappointing. Whether we can identify and rescue these drugs by, again, identifying the responders is still to be determined. And there are a number of combination therapies that I didn't include it here because they're in phase 2. They're very promising, but nivolumab was very promising. The phase 3 was negative, so I think we need to be a little bit more cautious or conservative and before we can jump to combination therapies. Finally, in the last 10-15 minutes, I will discuss a couple of concepts that we're working on in terms of the liquid biopsy space. I always like to start with this study that was published 2 years ago. So the authors essentially took all the gene expression data from TCGA, that includes more than 10,000 samples from different tumor types. And they did a very simple principal component analysis, which essentially analyzed the similarity between the different samples. So here you have all the samples, each dot is one of the different samples, and they're colored based on the tumor type. And what you see here is the principal component 1 that captures the major axis of variability in this data. The closer the dots are in this plot, meaning that the gene expression of the samples is more similar. What you see here is the principal component 1 is mostly capturing different tumor types, essentially, broadly. However, the principal component 2 is essentially capturing these samples as being different to the rest. So these samples are the HCCs. So if you concentrate all the samples in a single dot, and you do the same exercise, a PCA, you have here a cloud of dots with all the tumors, and then you have here HCC in the right top corner, which to me suggests that there are very intrinsic differences genomically or molecularly in HCC as opposed to the other tumor types, and we don't know what that is. It could be the fact that HCC arises in the context of chronic inflammation, regeneration, and that imposes a specific pattern molecular alteration. It could well be that, but we don't know, but there is objective data that HCC is different to the other tumor types. Now, we're trying to address 2 very specific problems in HCC. The first one relates with surveillance and early detection. We go back to the plot of the natural history of HCC. You know that patients with cirrhosis have an annual risk of 2-3% to develop HCC, patients with cirrhosis. We know that ultrasound and AFP has a sensitivity of 63% for early detection, and I just went back to see what was the first report of AFP. So the first paper linking AFP and HCC was published in The Lancet in 1970. So this was before I was born, and still AFP is a cornerstone of early detection in HCC. Well, I say the cornerstone, but it's included in the guidelines, which helps put a little bit of perspective in the whole precision medicine revolution, being AFP still in the picture. There are approximately 600,000 cirrhotic patients in the United States at risk of developing HCC, with an estimated risk of 2-3% per year. We can estimate 18,000 new cases per year. Out of these, if we apply the performance of the early detection tools, 63% of sensitivity for detection of early HCC, we can estimate to detect around 11,000 of these 18,000. So we have around 6,000 early HCC patients that we're not able to detect on surveillance programs. So that's the ideal, but it's not the true, because there's another factor we haven't computed here. So we have, again, the 600,000 cirrhotic patients in the US, 2-3% annual risk, 18 potential new HCC cases. We need to factor in how many of these patients are actually enrolled in surveillance programs. And this is very low, it's only 25%. Now we apply the sensitivity performance of our tools in these 25%, and we have a detection of around 3,000. So we have 15,000, 85% of the potential new cases that went undiagnosed because of the poor performance of the detection rate or because of the implementation. They're just not enrolled in surveillance programs. So how can we overcome these barriers? We can improve the accuracy of the tool, we can increase the implementation rate. So the ideal surveillance tool needs to be accurate, needs to be reproducible, that meaning operator independent, which is not the case because ultrasound is very operator dependent. When you look at the data from Europe, Asia, and the US, the rate of sensitivity for ultrasound are very different because it depends on who does the ultrasound. It should be easy to implement. So the patient has to go drive 1 hour to get to the hospital to do the ultrasound for surveillance. After 3 years of doing that and being the result normal, he may question what's the point of doing that. So it's easy to get attrition if you complicate how surveillance is conducted, as opposed to, for example, doing a blood draw and sending the sample locally for a central lab and analyzing more specific readouts of tumor. That is exactly what we're doing and encapsulates the concept of liquid biopsy. This entails the analysis of tumor components that are released to the bloodstream, to different fluids, but we're mostly interested in the bloodstream. This could be actual tumor cells in the form of circulating tumor cells, exosomes, which are small vesicles that contain different, mostly small RNAs that can be detected, or fragments of DNA that can also be analyzed. It's extremely convenient, liquid biopsy. If you think about it, when we talk about the evolution of the disease, with some lag in an HCC patient, if the patient was resected, you may have access to the tissue from the resection. But after that, the patient recurs, you get TACE, a couple of rounds of TACE, the patient progresses, you get systemic therapy, first line, second line. You don't have tissue of all this process. And we know that treatment imposes significant evolutionary constraints to the tumors. So it would be great to have a tool that could provide access to molecular information of the tumor real time. And that's what we're trying to obtain with this technology. The revolution of this technology didn't come in oncology, it came in non-invasive prenatal testing. And the concept is very similar. Placental cells, when they die, they release DNA that can be detected and is different to the mother. So we can analyze genetic material from the fetus by analyzing the blood of the mother. This was shown in a large study, including 16,000 women, to study trisomy of chromosome 21. They do the standard screening procedure, who has a sensitivity of 80% and specificity of 94% for the detection of trisomy of chromosome 21, which is very high. At the same time, the same woman, they sent a blood sample to a company that did the analysis on circulating free DNA to estimate the risk of the child having a trisomy of chromosome 21. Sensitivity was 100%, specificity was almost 100%. So you can imagine it's very difficult to get better than that. So it went mainstream. So non-invasive prenatal testing is now almost standard of practice for pregnant women. The number of tests is in the hundreds of thousands, and when you have that, there started to come, let's say, conflicting results. So the data that some mothers had in the blood were not compatible with trisomy of chromosome 21. Essentially, they had aberrations in chromosome 21, but they had aberrations in other places of the chromosome, which is not compatible, again, with Down syndrome. So how was this possible? And the reason for that is there was another thing contributing for the aberration. There was an undiagnosed chromosomal unstable malignancy in the mother. And this hit the press. It was mainstream. So by doing the analysis to detect chromosomal aberrations, we were detecting tumors in the mother, which bring the concept of can we do surveillance or use this tool for surveillance in the context of cancer, and there's a number of problems to that, but conceptually it's very appealing. In the lab, we're trying to use this approach, but instead of using DNA, we're using exosomes. So we did a pilot study where we showed that we can isolate exosomes from healthy controls of patients with HCC. The process of isolating is a little bit tedious, but there are different ways to confirm, and we're confident that we can isolate exosomes. We did a pilot study on 15 patients, 10 HCCs and 5 controls. We extracted the exosomes, we isolated the RNA, conducted whole RNA sequencing. We have a set of small RNAs that actually discriminate between HCCs and controls. So this is a pilot study. We now have close to 80 patients, and the sensitivity of the approach is around 85%, which is almost 20 points higher than the ultrasound plus AFP approach. There's a second problem that we want to address, is the issue of, is there a way we can provide any estimate of how we allocate treatments in a rational way? Because now, since the trials were running parallel, we don't know which drug is better, who should receive first Sorafenib or Lenvatinib or Rego or the other drug, so we'll try to address that. And specifically, we're interested in what we described previously as the immune-excluded class. So these are tumors that has no immune infiltrate, and they're enriched in beta-catenin mutation. A study from Memorial Sloan Kettering reported last year showed that patients with beta-catenin mutations do not respond to immune-based therapies, specifically immuno-oncology drugs. So you can see here the outcome of the patients with Wnt alterations was very poor, as opposed to the ones without Wnt alterations in the ones exposed to immuno-oncology drugs. And this was not discriminating outcome in patients not exposed to these drugs, suggesting that it's not a prognostic biomarker, it's a predictive biomarker. So we tried to analyze that, and we developed a technology to quantify or to detect mutations in the plasma of patients with HCC. We did a pilot study on 8 patients for which we have paired tissue and blood, and we, out of the mutations, we had an accuracy of 70% of the time. Now we do almost 90% for the detection of mutation. As you can see here, we validated with an orthogonal method. And we have this study that we're currently completing, where we have 82 patients with advanced stage HCC. Some of them were treated with systemic therapies, 52 patients, 37 with nivolumab and 24 with tyrosine kinase inhibitor. The majority, we don't have tissue because, as I told you, biopsy is not part of the management of HCC, so we cannot access genomic information. What we use is blood instead. And we have used the mutational profiling that I showed you before to see that the majority of patients have TERT promoting mutation as expected, and there are around 15% with mutations in beta-catenin. Whether these patients are the ones that do not respond to nivolumab that could help stratify future clinical trials, we still don't know, but it's in the process, and hopefully we'll have the data soon. So this is a summary of the potential clinical applications of liquid biopsy that ranges from early detection of minimal residual disease, analysis of clonal composition, prediction of response, so the applications are endless. But it's still on its infancy. So to conclude, I want to say that HCC incidence and mortality rates are increasing. The etiological landscape is changing with more NAFLD and less viral-related HCC. The outcomes for patients diagnosed at early stages are acceptable. We need to put more emphasis on improving surveillance and early detection of HCC. Systemic therapies provide modest efficacy, so there are a lot of options, but again, the increase in survival is modest. The role of checkpoint inhibitors and combinations is still unclear, and I think that liquid biopsy has emerged as a promising tool and a very convenient tool to develop biomarkers for early detection and response to therapy in HCC. Now, to finish by thank all the members of the lab, particularly Johan and Teresa that have been working on the liquid biopsy project, all the members of the liver cancer program, the surgeons that are very supportive, members of the division, Scott, who's in the audience, and other members of the liver division that's providing samples for the controls. And it's a very nourishing environment to develop these type of studies, and I thank you for your attention.
Yes, in the back.
So with oncology drugs, some of them work better if you give a big bolus and gets a high peak level. Others work better if it's given over a prolonged period of time and at even a lower dose. Has anybody looked at that difference in this disease?
Not that I'm aware of. The only thing that I recall is related to transarterial chemoembolization when the initial approaches, they induce a high peak of doxorubicin in blood that was associated with more toxicity but not to more efficacy. So in terms of the other systemic drugs, I'm not aware of any differences in terms of the pharmacokinetics and efficacy for HCC.
Any other questions? Ben?
So you mentioned that the checkpoint inhibitor studies were negative, but your gene expression profiling suggested that there clearly are certain tumor subsets which might have attractive features, and some of these might be similar to melanoma, I guess, the response to melanoma. So what do you need to learn, or what's the obstacle to finding out which patients may be responding, and the subset may be more responsive?
So I think the main obstacle is lack of access to tissue to run this analysis, because what you saw in terms of the signature, that was done on tissue samples. So the majority of patients are not biopsy, so we don't have access to tissue. Now, my impression is that the company will be very interested in analyzing, because in the trials they do biopsies, it's mandatory. So they will be very interested to analyze those samples and try to identify those 70% of the patients that do extremely well, because they do very well with oncology drugs. So maybe they could rescue these drugs based on that subset of patients. We're trying to use liquid biopsy to assess that. It's a little bit more complicated than using tissue because it's difficult to estimate gene expression on liquid biopsy, but there are some workarounds that we're trying to use to, again, identify the patients that would respond, that would eventually save or, repurpose or reutilize these drugs.
Perfect talk, Augusto. You're modest in that you didn't describe your own studies of tumor heterogeneity, so I'll do it for you, but ask a question. One of the challenges is that you not only have underlying liver disease, you also have many tumor types within a single nodule. So maybe you could expand on that, and how do you choose which of the genotypes within a multifocal tumor is the one that we should be targeting? Any thoughts?
Well, now that you ask me.
We didn't plan this.
We didn't plan it.
Sure.
So, yeah, it's true. So when you look at a tumor nodule and you do multi-regional sampling and you do a number of genomic studies, you see that some of the tumors, not all of them, but around 25% are very different. They're very different in the tumor clones, and they're different in the tumor microenvironment. So the good thing is that the major driver mutations in HCC, they're distributed homogeneously in all of the regions, so that's good. And the other good thing is that the percentage of highly heterogeneous tumor in the single nodule level is relatively low, it's around 30%. But I have to say that we don't know exactly how to interpret, how to integrate this data in clinical practice, mostly because, you cannot think about doing 4 biopsies to a patient. With one, it's enough, no? So doing 5, it's unreal in terms of implementation. But it's a major limitation. We're starting to understand which is the relations between all this ecosystem of cells, tumor-associated fibroblasts, immune cells, and how we can leverage that information to maximize response, particularly when thinking about combining immune therapies with tyrosine kinase.
Are there any other cancers that are this heterogeneous that people look? Breast, colon, pancreas, prostate?
So I think in terms of heterogeneity, intratumor heterogeneity, glioblastoma is also very heterogeneous. And ovarian cancer is also very heterogeneous.
Back there.
Oh yeah, you talked about the upregulation of beta-catenin. So I'm wondering, in your sequencing data, did you find any of the epithelial mesenchymal transformation associated with progression of disease metastatic HCC?
We haven't looked specifically to that. We have the data and we can query that. We have so it's been described around 30% of the patients with mutations of beta-catenin and around 5-10% with mutation of AXIN1. They're mutually exclusive. But I don't recall looking at that specifically. I can have a look.
Yeah, the principal component analysis was very dramatic, and you raised the issue of the uniqueness of the pathophysiology, and you raised the issue of it being in response to inflammation. So I was wondering if you've had a chance to look, let's say, at gallbladder tumors or scar tumors where, again, the hypothesis has been that this is at the end of a very long inflammatory process.
No, we haven't, and it's a very good point. And I think that if we look at those primarily inflammatory-related malignancies, we'll see some signal, some shared signals between HCC and those tumors. But it's true that it's not only inflammation, there's a component of fibrosis and regeneration that is not exactly the same as in other tumors. For example, if you think about it, the liver is unique in that their cells are polyploid. No other, they're other, but it's very rare to have polyploid cells. And we don't know what's the mechanism for that. What's the purpose of that polyploidy? So you have 4N, 8N, and it's physiological. So that could also contribute to this difference. Maybe it's unclear, but I think there will be a link if we compare inflammatory-related malignancies.
One other thing, there was a very dramatic difference in the ability to differentiate the groups in the training set and in the actual analyzed set in the gene profiling slide that you showed. And I was just really curious if there were an understanding of why there was such a deterioration from the training set.
You mean this?
No, there was. I don't want to take up other people's time, but keep going back where you showed the two curves for the training set and for the actual set. And the
Oh, yes, I know what you mean. Yes. Yes. This one.
Yeah, that was a bit disappointing.
Well, so the way this works is that when you train a gene signature in a data set, by definition it's overfitted. It's the perfect condition. It's the perfect way to discriminate. That's why it's so good in the training set. You cannot use that. You need a validation set that it never works as good as in the training set because it's overfitted for that.
That's still a pretty good training set.
No, it cannot get better.
Yes.
It doesn't get better. But it was significant independent cohorts. So the patients were, it's not that we split it in two. It was a completely independent set of HCC patients
Sure.
from France, and it was validated.
There's still a lot of variability. I mean, there's clearly other clusters within the HCC group.
Yes, yes.
So is that getting to the so is getting to the heterogeneity in it, or is it just are they behaving totally differently?
No, I think it's to the heterogeneity.
Okay.
But yeah, the different subclasses, we're looking at methylation within the different groups, yeah.
Okay. Thank you very much.